I think that's going to be absolutely crucial because right now, in surveys and interview data with different patients or the public, what they say very clearly is they want research. They want to know what works. They want to learn more about how to get good science and good treatment and get better treatment. But it also is very clear that they want to be able to give consent. But there is, in fact, a very deep-seated trade-off often between those two. The more rigorous and restrictive the consent requirements are, the more substantive the consent requirements are, the less people wind up enrolling in research, the more biased the samples are, the more underrepresented groups wind up being left out of research, and the less valuable the research is. And so getting people to understand that trade-off, I think, is going to be absolutely crucial to developing policies that really get people to recognize that what we're really dealing with is a public good, and that we really need to take that into account as we're building this new infrastructure for precision medicine taking place in a learning health system. So the reality is that the nature of medicine has been changing for a long time, but our image of medicine, our impression of what it means to be a physician, what it means to be a patient, has not really kept up with those changes. The vision that people have is of a dyadic relationship between a patient and a physician, a one-on-one relationship at the core of medicine. But the reality has been for quite a while that medicine is increasingly being provided by teams of physicians and different kinds of practitioners, and it's been provided through healthcare systems, larger structures, where a lot of the decision-making is taken out of the hands of physicians and in all kinds of different ways, and that those decisions are very limited, but in ways that are often invisible to patients. I think with artificial intelligence, with machine learning, we now have decision aids and decisions that are likely to be made increasingly by healthcare systems and even by individual physicians based on these algorithms. And that it represents potentially both a fundamental change and shift in the nature of the relationship between patients and physicians, but also a revealing of some of these shifts and patterns that have been happening for a long time. I hope that what we can start to do is to rethink the nature of the relationships between patients and physicians, to recognize increasingly that what's involved are communities of practitioners, communities and institutions that are providing care to populations and communities of patients, and that there are obligations on both sides in that equation, not just one side, and that we can change and develop a new ethos that's much more communal than the current ethos that's really grounded in the notion of a single physician and a single patient.